We are live.
Good evening, everyone. Welcome to iFocus Online, lecture number 543 of Optics and Refraction, module number 18. Today, Dr. D. Chandrasekhar from Aravind Eye Hospital, Coimbatore, will be talking to us on the topic Astigmatism, Anisometropia, and Aniseikonia. I would like to introduce the moderator for today's class, Dr. Amita Kaul ma'am. Ma'am has done her MBBS and MS Ophthalmology from Government Medical College, Jammu, and she has completed her fellowship from Rajiv Gandhi University of Medical Sciences. She has been trained at Narayana Netralaya, LV Prasad Institute, and Shankara Eye Foundation. Ma'am is a corneo and phacorefractive surgeon. She is currently the senior consultant at Center for Sight, New Delhi, and she is involved in teaching and training of DNB students and anterior segment fellows. She has about 20 peer reviewed articles and publications on cornea, cataract, and refractive surgeries, and she has delivered many lectures in national and international conferences. We welcome you, ma'am, to the iFocus Online.
Thank you for that kind introduction, Sureen. It's my absolute honor to be introducing our today's chairperson, Dr. Tuleka Chauhan ma'am. She has done fellowship in FACO from Venu Eye Hospital and anterior segment fellowships from Vasan Eye Care, Bangalore. She also has clinical and research fellowships from Mass Eye and Air and Stein Eye Institute in California, Los Angeles. And she has a certification for management of low vision in LVPI, Hyderabad. She's currently a senior consultant in cornea, external diseases, cataract and refractive services at the Center for Sight Eye Institute, New Delhi. And she is heading a lot of clinical research and trials that happen in the Center for Sight. And she's also the fellowship program coordinator at CFSEI, Dwarka. It's also an honor to be sharing screen with and introducing our today's speaker, Dr. D. Chandrasekhar, sir. Sir is the medical consultant and NABH coordinator for Aravind Eye Coimbatore, and he's a gold medalist in ophthalmology from Tamil Nadu, Dr. MGR Medical University. He's a recipient of Star of KG Hospital Award from Dr. APJ Abdul Kalam and has been awarded Tamil Nadu Ophthalmic Association Dr. J. Agarwal Award for Teaching Excellence in 2022. He is also held the chair of AIOS Adverse Events Committee in 2025-26, and he's the honorary secretary of Tamil Nadu Ophthalmic Association currently till 28, and he's a certified NABH assessor and AIOS National Resource Teacher and an expert member for creation of first edition of NABH Eco Standards. He has conducted and mentored several quiz programs with state and national recognition and is the founder and co-host of the VRV DC Online Forum in Ophthalmology. We welcome you, sir. And without much ado, I hand over the mic to you now.
Thank you very much, iFocus team, Dr. Santosh Honover, Center for Sight, and all the organizers for this wonderful opportunity. This is my first talk with iFocus Online. Thanks once again. So can I share my screen? Yeah.
Yes, sir.
Yes. Seen?
Yes, sir.
Okay. It is in slideshow?
Now it is, sir. Yes,
Yeah,
sir.
yeah. So very good evening, friends, and it is lovely to be here. So I've been given 3 good topics from the PG's point of view. Is it not? Okay. So these are the topics: astigmatism, anisometropia, and aniseikonia. All 3 are equally important from the exam point of view. So I have, as an ophthalmologist, the least we concentrate is refraction. I'm so happy that iFocus is going into the minute aspects of refraction, and this is one of the chapters. So we have to know how to see the vision, how to do the refraction, and you should know, because at the end of the day, as an ophthalmologist, you will be signing the drug prescription and the glass prescription. So if you are going to give one raw, I remember, when a few years back, an institute gave about 0.5 wrong power, and a fellow got about 70,000 rupees as claim for 2,000 rupees glasses, this thing. So this can happen, and today in the era of medical legal cases, we need to know exactly what we are doing and what we are actually looking at. We should be able to find out false. And the most important thing is it has got a lot, and we are dependent on the optometrists and the refractionists for this. But still, they do a great job because the foundation of any eye hospital is a good refraction, good vision. That is what the patient wants at the end of the day. That we know, we should know whether they are doing it properly. Now, the visual acuity testing is the most important. We have visual acuity as uncorrected with pinhole and best corrected. This is a common classification apart from the other ones, which is beyond the scope of this lecture. So what is astigmatism? So most often in any of the FAT exams or any of the exams, when we ask them what is astigmatism, there is always a slur. The most important point is it is a refractive error wherein a point focus of light cannot be formed. So at this point, I'll ask a question for you to think. Is it a problem with distant vision or near vision? What does it ring in your mind? See, this is not a problem with distance or near. It is a problem for any vision. That is why when you come later on, you will see you bring the cylinder down for near vision also. So a point focus, suppose there is a point of light, this point of light cannot become a point of light there. So this is how the vision can appear depending on the types of astigmatism on the right bottom. So in a normal eye, with your so-called for emetropia, with accommodation at rest, parallel rays of light coming from infinity will fall to a focus in the light sensitive layer of retina. So that is okay. But here multiple focal points happen. Minimum two will happen, or depending on the type of astigmatism. That is the major difference between these things. So here you can see what happens. The focus of the two multiple points are not at the same point. So that will be causing blurred vision and distortion of vision, which is more irritating for the patient. Now this is what will happen, as I told you. Right. What are the causes for this? If you look at the optical defects, we classify them into physiological and pathological. Physiological are those like diffraction, decentering, peripheral, all those things. But in the pathological, the two important things that can cause astigmatism are curvature anomalies and obliquity of the elements. So these are the things. There are other things like absence of elements, other things like axial length, presence of elements, and so on and so forth. But the two things you have to remember, one is curvature anomalies, the other one is obliquity of the elements, usually which occurs at the lens level also. So the corneal astigmatism, a lenticular astigmatism, and rarely the index will be with respect to the lens. So this is very important for us to know, especially in diabetics. We have two types, the regular astigmatism and the irregular astigmatism. So 95% of the times in the regular astigmatism, they cut at right angles to each other. That is, the cutting will be 90 degrees to each other. Then it is called a regular astigmatism. When the principal meridians are not at right angles, then we call it irregular astigmatism. Now, why did I say 95% of the times? Because there is one regular astigmatism where it will not cut at 90 degrees, which I'll come to you shortly. Now, if you see here, with the rule astigmatism, you remember you put the plus. So the plus, the straight horizontal line, you put minus. In the vertical line, you put plus. The horizontal line, you put a minus. Vertical line, you put a plus. This is called as with the rule astigmatism, which is in a normal eye because of the pressure of the upper lid of the globe. So with the rule, minus at 180 and plus at 90 is called the with the rule astigmatism. Now what happens with the against the rule? Just reverse that. Plus at 180 and minus at 90. So this is called against the rule astigmatism, which can occur following cataract surgery and so on. So these are two main things in regular astigmatism, with the rule and against the rule. Minus 180 and plus 90 is called with the rule, and plus at 180 and minus at 90 would be called as against the rule. That is very simple. The other one I told you is oblique astigmatism. It can still cut at 90. If it is 45 degree, at 90, it will be at 135. So though they don't cut at with the rule and against the rule is only for vertical and horizontal being at 90 and 180. And this is called oblique astigmatism when it is like 60 or 45 and so on. This is something which is called as oblique astigmatism. Remember, I said 95% of the 90-degree cutting will not be obeyed. In bi-oblique, it will be like an X. In an X, both the opposite angles are same, but they may not be at 90 degree. So 30, 30, 100. Like that, it will be whatever. Both the opposite angles will be same. This is called as bi-oblique astigmatism. So both the angle, like this and this will be same, this and this will be same. So these are the basic types of astigmatism. Irregular is nothing but totally distorted. It could be due to conditions like keratoconus, corneal abnormalities like keratoconus, abrasions, and scar. When there is some pressure on the globe from external, like example, is the any lid tumor, chalazion or something like that, then it causes distortion of the globe. These are called induced astigmatism. So they all come under that. Very rarely in an incipient cataract also you can get, and of course after penetrating keratoplasty, where suturing it could be tight on one side, they can cause obliquity or curvature anomalies. So that is the basic classification of astigmatism depending on the axis and how it cuts. Clinically, we have three types of astigmatism, which are called as simple astigmatism, compound, and mixed. So very simple. Simple is one axis will be at the retina or the light sensitive layer of retina rods and cones. One is on either the inside, which is the myopic, or outside. You can see here, one on the left is focusing inside and one is on the retina. So that is a simple myopic astigmatism. And the other one, it is focusing on the retina. The other one is beyond the retina, which is simple. A simple astigmatism could be simple hypermetropic or simple myopic astigmatism. Whereas in compound, neither of them will fall on the retina. Neither of them will fall on the light sensitive layer of retina. So that means they both are in the either inside or outside. Then it becomes a compound myopic astigmatism. If both are inside, short of retina or back beyond retina, it is called compound hyperopic astigmatism. And the third one is inside, one is outside. As simple. One is falls in front of the retina, the other one falls beyond the retina. So mixed astigmatism, which can also be called as antimetropia. Mixed astigmatism is also called as, so we have seen direct and that based on classification, with the rule, against the rule, bioblique or irregular. Based on clinically, it could be simple myopic or hypermetropic, compound myopic or hypermetropic, and mixed where you have a combination of myopia and hypermetropia there. This is called mixed or antimetropia. Here you can see that simple myopic, simple hypermetropic, compound myopic, compound hypermetropic, and mixed. So that solves all the causes and classifications. So these are the types of, how a patient really sees depending on the type of astigmatism, which is clearly described. And this forms the basis for one of the tests called as astigmatic fan. Now, this is commonly asked in the exam, conoid of Sturm's conoid. Now, what happens? Actually, you can create any refractive problem using the Sturm's conoid. Here, if you say two axes are there, here you can see where one is focusing in one area, the other one is focusing beyond. So, if you have the retina here, for example, if you have the retina here, what's happening? Both are getting focused behind. So it is still not yet focused. If it is going behind the, your wherever retina should be, then it is called compound hyperopic astigmatism. Whereas when you see here, one is focused at the retina, other is still going behind the retina, which is called the simple hyperopic astigmatism. Now, here the other one thing you should remember is you have one which is called one in front and one in behind, which is called mixed astigmatism. Now here where the rays cross, there is one small area here which is called the circle of least diffusion, at which point if you give the correct correction, the patient will get the best visual acuity. Similarly, one is focused, one is in front, one is focused, both are focused. You have the simple myopic and the compound. So if you put retina here, what will happen? If you put retina here, retina, you get all types of astigmatism cleanly explained in the Stump's conoid. So what happens when astigmatism? It is very troublesome for the patient. It can have fatigueness, they can have headache, they can sometimes they have to squeeze their eyes, which again causes more stress on the patient. Then you can have blurred vision holding, they may have to hold the reading material closer to their eyes. Tilting of the head can occur and running together of the letters where again it may not be clear like how you see like this. So all this are very troublesome to the patient. See, whereas the myopia, hypermetropia, blurring is there, but this is something more than blurring, which is more troublesome for the patient. So what all do we need to do for a case of astigmatism? The gold standard for finding out powers. You have any number of automated machines to find out the power of the patient based on which we can work. Still, you must remember retinoscopy is a gold standard. It gives us wonderful results. Then keratometry will give you the curvature. I'm not going into the other things. Then you have the astigmatic fan and the Jackson's cross cylinder. So these are the important things. Now, as you see here, you can see this is the basis of retinoscopy. You can see it is moving with the as the beam goes one side, the light also with the movement. Remember, you don't tell myope hypermetro. If you do that, if you see with the movement, you just put plus lenses to neutralize. If it is seeing, you are seeing against the movement, you have to put minus lenses to neutralize. That is the most important thing. So here you can see with them. See, if you do at 1 meter, no, please remember with the movement can occur for emetropia, myopia, and hypermetropia. Whereas myopia will always be against movement. And if you're doing at 1 meter, it will be against movement. Okay. So remember, the main thing is emetropia, everything can be with the movement depending on the distance. Why? Remember only one thing. You have three stages of retinoscopy. Only when the image falls projected between the patient and the observer, it will be against the movement. Behind the patient, behind the observer, at the patient, everything will be with the movement. If it is between the patient and the observer, it will be against the movement. And if you have no movement, that means it is falling at the observer side. Plus or minus no movement, that means minus one diopter. That's all. So this is a principle. I'm not going into basics of retinoscopy. This is beyond the scope. Here you can see in the live patient, you can see beautiful movement with the movement. You're changing the axis. So it is a regular astigmatism. You can see clearly. So it is going with the movement. You have to put plus lenses to neutralize. On the other hand, here you can see it is against the movement. So always remember, tell your institution to get some model eyes. Do not try for half an hour, 1 hour on a patient. It is not good. So model eyes are wonderful. You can set the power, you can set the cylinder, everything, and try. And this is how this reflexes will occur. No, this is all regular we saw with the 90 180 degree. But when the astigmatism is not with 90 180, there are four characteristic features of regular astigmatism but oblique axis. So there are four features which will tell you it's an oblique astigmatism. One is normally you have three things. It will come straight like this. The ray of light from the iris, the pupil and the iris, it will come straight. So even wherever you say, 30 degree, 40 degree, it will remain. So this will become broken. It will not be like this. It will come, it will get broken and come like this. This is called the break of a oblique astigmatism. Unless you put it in the, aim the light together, it will not become straight. If you look here, if it is aligned, it will become thinner and crisper. If it is not aligned, it will become wider. So one is the break. The second one is the width. Only when it is aligned, it will become crisper, just like your neutralization. Brightness will be much more when it is aligned rather than not aligned. So you have the break, you have the second one is the width, this is the break, this is the width, and then is the intensity. And the fourth one is more fascinating. Here you can see, 1 minute. Yeah, you can see now. Can you see we are moving? It is also moving with the, but if you see, it is not moving parallel. It is not moving parallel to the light. So this is called as skewing. This is called as skewing. Okay. Okay, after skewing, what you should know here, okay, here I will show you one more thing. So the four features of oblique astigmatism is the break, the width, the intensity, and the skewing. Now, what is this straddling for oblique astigmatism? I find out, neutralize at 45 degree. So you need to know if you rotate the axis on either side 45 40, the differences, the break, the intensity, everything should be just like what? What does it remind you of? On either side 45 degrees, you try and see how much of the difference. Both sides it should be equal, then only your axis is correct. This is nothing but something similar to correction of the power using the Jackson's cross cylinder. This is the same principle. This is called straddling. Sometimes you do get a reflex like this also in irregular. Can you see that scissoring? One is going in a different way, the other one is going in a different way. So you can see the scissoring reflex of a keratoconus, which is also an astigmatism. Now, for the third important examination would be the Jackson's cross cylinder. So, what is this Jackson cross cylinder? It can be of zero point 0.2 diopters or zero point 0.5 diopters. Remember, there is a sphere. Say, for example, if I have a zero point 0.5 sphere, there will be one axis, minus one, opposite cylinder. Okay, so ultimately, the difference will be plus 0.5 versus minus 0.5. Or you can have a 0.25 sphere with a minus 0.5 cylinder. So the difference in the power will be plus 0.5 minus 0.5 or plus 0.25 and minus. So what can it test? One, it will make sure your power correction is good. Number two, it will also make sure your axis correction is good. That is the principle of the Jackson's cross cylinder. So if you see here, this is how you flip, you don't remove and so you have to flip. So you need to understand for the powers, you need to put in line, the handle should be in line with the axis. You flip and see both. When you flip, it should be equal. If it is more on one side, then you have to recorrect the power. For correcting this, you have to recorrect and check the power. So this is the fine tuning of the power. Similarly, you will see. Okay, here this is flipped. Then you can see it is the angle. The angle is done with the handle of the Jackson cross cylinder, just to make sure the power. One is the angle is correct or not. The second one is the whether the power is correct or not. First, what we saw is the power. Then what we saw is the angle. So 45 degrees each side, both are abnormal, both are equal, then it is correct. So power, both sides 0.5, 0.5, both are equal, then your cylinder. Otherwise, you need to fine tune. This you will understand only when we sit and do. What first we saw is the power. Second, what axis, and then what we saw is the power. So this is how we fine tune the power and the cylindrical value using a beautiful Jackson cross cylinder. This is how we have to do. You can see that. You see just like that, you have to see the axis and the power. Now, what happens in an astigmatic fan? So normal spherical person will be able to see all the lines clearly. Whereas when you see at the bottom, there is a problem, a clear axis in the 90 degrees. That means your cylindrical axis is good. Some are blurred. So fine tuning the cylindrical, spherocylindrical power, the astigmatic fan can define whether your correction is good or not. Now, what are the treatments available? I'm not going into the depth. We have got wonderful refractive surgeons here. So basically, we can give lenses. Lenses could be spherocylindrical or cylindrical depending on whether it is simple or compound or something like that. And the lenses can be given. Apart from that, we can give cylindrical lenses. There is a limitation of how much of the power an RGP can correct or hard. So we go on with the contact lens correction. Spherical lens correction, contact lens correction also can be taken. Small astigmatism about 0.25 to 0.5, unless the patient is symptomatic and really not a problem, you need not give unless the patient is not happy. A little moderate to higher, you need to give full correction. Very high, you can give slow initially less correction and later on you can move on to higher correction. If the axis is changed, patient needs to work again. Otherwise, you also have to find out whether the fit of the glass is also good. Sometimes we're not accepting it, pulling the glass up and not centered. These also can cause problems to the patients. So These are things that will be done as a basic thing. As far as laser surgeries, you have photorefractive keratectomy, LASIK, SMILE, small incision lenticular, and now recently the small incision lenticular keratomy. All these are good, but the limitation of astigmatic correction will vary from one procedure to another procedure, and you should be cautious in high astigmatism. So this is how we basically define, classify, how to investigate, work up, and then treat the different types of astigmatism. Now, with the benefit of you people, I will show you how to work out a, I'm not going into all the details. I'll show you how to work out a oblique astigmatism. For example, if it's a 10-year-old child who is on cyclosin and pseudophakic, patient has a pseudophakia. Okay, remember these three things. We do the refraction at 1 meters. So what happens at 70 degree, it is 1.75 plus. So I'm doing at 1 meter. And what is the opposite of 70? At 90, it will be 160 degree. This is the basic problem of the patient. Now, the power cross, that is called the power cross or the retinoscopy value. What will be the next thing? I want to do the distance correction. Since I'm sitting at a distance of 1 meter, the distance correction is 1 meter. So 1.75 becomes 0.75 and the 3.5 becomes plus 2.5. That is the distance correction. What do we do next? The third part of the retinoscopy would be doing a subjective. First is the power cross, second is the distance correction, third would be a subjective. So how do you do don't do everything in the trial frame, then you'll end up giving a wrong power. So when you have two powers, take the smaller power as the spherical power. Here, which is a smaller power? Plus 0.75 is a very small power. So you put plus 0.75 spherical, that means it is there all around. The other axis is also plus 2.5. So already 0.75 is there. Just subtract 0.75 from 2.5. So what happens? It will be 1.75. So what will happen? So I will give a subjective of plus 0.75 diopter spherical and 1.75 I will give at 70 degrees. Only then it will act at 160 degree. Okay. Now what is the problem in this subjective? Both are plus. Ideally, a patient will accept a minus cylinder better than other thing. So what do? You add algebraic sum of both, which is plus 2.5, plus 0.75 plus 1.5 is plus 2.5, and change the symbol and the axis, minus 1.75 at 160. Only if you give at 160, it will cut off at the 70 degree. Now, how do you know whether the spherical power is correct or wrong? Look at the other axis, it is 2.5. That only will become the spherical power. This is the fourth step. So then I told you first is the power cross, second is the distance correction, third is the subjective, fourth is transpose if necessary. What is the drug correction? Remember, I said 10-year cyclosin, you should be giving drug correction, but this is a case of pseudophakia. There is no accommodation. So there is no need to give drug correction. So what will be the near vision correction? Normally for a 10-year-old, you will not be giving any near vision correction. Whereas this is a monofocal IOL, you need to give ideally a plus 2.5 correction. What will be the seventh step? You have to write the prescription. Always write like this, spherical. I told you plus 2.5 minus 1.75 at 160. This is what we calculated. Remember? Plus 2.5 minus 1.75 at 160. So that is for your distant vision. It is 6.6. And what do? You have said add plus 2.5. To the spherical, you add 2.5, it will become plus 5. Remember, astigmatism will come there also. Bring down the minus 1.75 and a 160 degree without changing. It will be there for near and distant, and that is N6. What is the eighth step? Eighth step is only simple. It's a pseudophakia. If you want to make a refractive diagnosis, it is a compound hypermetropic astigmatism oblique axis. There is no question of with the rule or against the rule. So these are the 8 steps of the retinoscopy value. Now here you can see a prescription again plus 6.5 minus 4.5 plus 5 minus 2. For near vision, they have added 1 and put N6. So with this, the optician will make a glass, but from the exam point of view, do not write like this. Always bring it down and write. That is the best way to Write the prescription. Plus 6.25, add 1 plus 1, bring down the cylinder. 5 will become 6. This is the correct way of writing a glass prescription. At least till you finish your post-graduation, this is the ideal way of writing. So that leaves it with the first part of the talk. Next would be your anisometropia. It's very simple. There is inequality between both the power, refractive power of the eyes. Okay, this is called anisometropia. That is simple as that. Now, the causes could be congenital or developmental due to differential growth in the eyeballs. One could be very fastly growing, like a uniocular myopia. Acquired could be a aphakia from trauma or mild differences in refract. What can happen? These things, about 1.5 diopter to 3 diopters is tolerated. Why? Remember, each diopter will cause mimification or magnification of the image by 2 to 3%. Each diopter. So, up to 6 to 8% we can tolerate. Beyond that, it will cause distortion of vision. That is called a differential power of more than that will cause. For example, a phakic patient will have plus 10 diopter. It will cause 33% magnification when you correct. So what happens in these conditions? The abnormal eye image will get suppressed unless you correct it. This is called anisometropic amblyopia. This is the part of the anisometropia. When one eye is hyper, the other is myope, then hyper can be used for distant vision and myope for near vision. You remember the other name for myopia is called nearsightedness. Hypermetropia is called distant vision, farsightedness. This is not a near vision problem, but this is for the distant vision. It is simple terms. Even in school we learn it is nearsightedness for myopics and farsightedness for hypermetropics. Uniocular vision, of course, there could be a problem. That could be ametropic amblyopia. This type of amblyopia could be anisometropic or ametropic. One eye is normal, then you will have it an ametropic amblyopia. So then these are the types of anisometropia. Remember, just like your astigmatism, simple anisometropia. That means what? One is emetropic, the other is abnormally myopic or hypermetropic. That is called simple. Compound anisometropia, both are myopic or both are hypermetropic. Mixed is and anisometropia is usually called antimetropia, whereas mixed astigmatism, we don't call it, you only say mixed astigmatism. When you have mixed like this, you call it mixed anisometropia, which is ideally called as antimetropia. As far as mixed astigmatism, you tell in the exam only as mixed astigmatism. The other name for mixed anisometropia is better to be told as antimetropia. Then you have the single astigmatic, one is normal, the other eye, or compound astigmatic or mixed astigmatic. So this is almost, the classification is similar to your astigmatism. These are the clinical types of anisometropia. These are tests you must remember. So friend test you see in the drum, Snellen's drum. So fin red. Fin will be in what color? Green. Red will be in red color. Remember, you put the Armstrong goggles, red in front of the right eye and left in front of the green and test. Okay, in the front, you have green and red. If all are seen, the patient has got a good binocular vision. If red are seen better than the green, that means if there is a left suppression and the left green better than the then there is the right suppression. So that is how you. Then this is again, how you read and then take a decision and make to use it for correction. Worth for dot is similar to friend test. If you see here, you will have two greens, one red and one white. That is a normal binocular single vision. If it indicates, like if you see two reds, what are you seeing? Right is seeing properly and two reds means there is a left eye suppression. If you see three greens, left is seeing and the right eye is suppressed. If, both two reds and three greens, that means you have a alternating suppression and it can be diplopia also. So these are the things you must understand from a Worth 4 dot test. So this you saw, you have the two things here. What are the two things? One is the goggle. The torch is for near vision. You can do the Worth 4 dot for near vision as well as distant vision. Okay. Now, how all can we correct? So basically, spectacle is going to cause beyond a certain thing, it is going to cause diplopia. So contact lens, what happens? 33% in an aphakia becomes 16% when you put a contact lens, and it becomes much lesser when you put an anterior chamber intraocular lens. And if you put a lens in the back, it is almost equal. So that is the variation, and contact lens has a good role in anisometropia. Then you can do the surgeries like removal of lens and so on and so forth, and refractive surgeries to correct at the cornea level. So these are the grossly treatment options available for anisometropia. Now, what is this? Aniseikonia is inequality between the images of two eyes, either the size or the shape. It can be the size or the shape. Okay, not equal images. That is the meaning of aniseikonia. These are the two things you have to see. So the etiological classification, it could be due to optical purpose, it could be due to retinal, and the third one, which we will not be dealing, which is probably by the cortical and how it conceives the images. So if we are at our point, optical and retinal are very important. Optical is when there is a acquired anisometropia to a higher degree, it will cause diplopia and inequality and so on. But when you have arrangement of the nerve fibers, or elements, rods and cones, then when they're close, you get the distortion can be there. When the macular edema, they are separated. So these things uh, cause you aniseikonia, which you can also detect by your Amslet chart. So clinically, there are symmetrical and asymmetrical. Clinical is overall, it will become big or small. Whereas meridional, in only one meridian, it will become elongated. Asymmetrical or regular, irregular, and pincushion, like what you get in your effort in your aphakia also. So here you can see symmetrical and you can see distorted in the right. Clinically, symmetrical can be overall or meridional, asymmetrical line. This is how you classify aniseikonia. Here you can see the global enlargement or mimification or elongation. Every type can be explained in these images. So again, like anisometropia or astigmatism, it will cause asthenopia, difficulty in reading. There can be other symptoms like vertigo, nausea, headache because of the distorted images. If it has been persistent since childhood, then the other eye would have got suppressed. But if it is coming suddenly, doctor, I cannot see this, this has become distorted, I'm not seeing some, then it becomes a problem. Now, measurement of this aniseikonia can be done by any of these iconometers. These are called iconometers, a standard or a space, or by rough estimate by the rule of thumb, it calculates. I have not seen one being done, but the iconometers, either the space or standard, will help you to ascertain what kind of aniseikonia a patient has got. As far as treatment is concerned, you can give aniseikonic or isoconic glasses, which will correct the distortion to an extent. Contact lens will eliminate abnormalities to an extent. Lenticular surgeries and corneal procedures will help, like laser and so on. Whereas retinal and cortical, you have to treat the primary cause to eliminate. Unless the elements become formed again, reduce the edema, distortion goes, then the power, without the losing of the power of the function of the retinal elements. So this is the cross way you treat the aniseikonia. So okay. So what all this thing I told you of contact lens implantation of IOL, you want to minify the basic problems of the anisometropia or the power and the variations. Retinal, of course, you need to treat and the cause. So ultimately, when we do all of this, we want to change a blurred vision into perfect vision. How we are going to do it depends on each of the condition, and it is our discretion that we will play according to the best practices. So this is in short about astigmatism, anisometropia, and aniseikonia. You go and try out your refraction, Jackson cross cylinder, retinoscopy. Once you do only, you will be able to understand. This is just a idea to give you a kind of motivation to do this yourself. In the exam, suddenly one day you cannot do. You do at least 10-20 cases during your posting. And in the exam, when you see a long case, please make sure you see the refraction yourself and present. That practice will go a long way in helping you in the exams. So this is about my talk on retinoscopy, astigmatism, anisometropia, and aniseikonia. Thank you so much, panelists and iFocus team and organizers and Santosh sir and Center for Sight. Madam, over to you, madam.
Thank you so much, sir. It was such an enlightening talk. I would like to ask Surveen first if we have any questions.
Ma'am, we have few questions. One is, what is the impact of lenticular astigmatism on the total refractive astigmatism? This
No,
is from the online platform.
okay. The lenticular astigmatism will occur when there is obliquity of the lens. When the cataract becomes, definitely it can be oblique, it can be subluxated. So in principle, that is difficult to correct. So that is why when we have a subluxated, temporarily also if you want to correct, you correct the aphakic portion of the eye, making sure that there is no differentiation or don't correct. So it will have, depends on the anterior subluxation will cause a myopia. If that depends on the pre-existing refractive status. Suppose the patient has got already a refractive error, it will be overpowering that and adding to it. That's it. That is how we calculate on the overall. This is what I understand. Madam?
So Reen,
Yeah,
any
you
other
can
questions?
add your comments also. It will be good. I have no issue at all.
Sure, sir. Another question, again from the online platform. What are the causes of induced astigmatism post phacoemulsification, and how can we minimize it, sir?
So basically, what happens today, phaco is not only phaco. It's called keratorefractive procedures, phaco-refractive procedures. So pre-operative assessment of the refractive status. Even if you're doing an SICS, you can put the incision in the steepest meridian. You need not go at 180 or 90. So pre-assessment will definitely help to eliminate to an extent. So you classify up to zero point 0.5, you don't bother. Mild astigmatism up to 1.5, you can correct. Beyond that, it becomes difficult. So number one, when you do SICS. In phaco, you can go to an extent and go to the meridian. Of course, today you need to understand glaucoma also you have to keep in mind, in future you may have to take the area for anti-glaucoma. And the third one is the femto procedures today will take care of astigmatism. Also, it is all fed into the computer. It will do keratotomies, astigmatic keratotomies also along with the procedure.
So, sir, if it's okay, can I add a few things in here?
Yeah, absolutely.
So,
I'll be happy.
yes, thank you, sir. So, when we talk about induced astigmatism post phaco-cataract surgery, so one is the thing that you have just mentioned about corneal incisions, that the size, location, the architecture of the corneal incision, how we make the incision, it can itself alter the corneal curvature in some way. And we also know that when we make an incision on the steeper meridian of the cornea, it will tend to little bit flatten
Flat.
that meridian, which causes some amount of surgically induced astigmatism, which, as you yourself mentioned just now, that we can actually choose where we want to make the incision so as to flatten out the cornea a bit. The second thing, which is mostly not in our control, is wound healing and scarring that sometimes happen.
That is acquired.
Post-operative wound healing, right, so fibrosis, scar contraction, all these things can cause changes in corneal shape. They can exacerbate previously existing astigmatism or induce a new form of astigmatism if the wound healing is not proper. Because nowadays the wounds that we make in phaco, they are entirely clear corneal. So it also depends upon how the cornea is healing. So sometimes the if we put very tight sutures, say, that can steepen the cornea locally, while as if there is wound dehiscence, that would flatten the cornea. So similarly, there are intraocular factors. If the lens has not been put correctly, like if one haptic is inside the bag and one is in the sulcus, that might cause some kind of tilt, or if there is decentration of the IOL or some malposition, that can induce astigmatism again. Like just now we were talking about lenticular astigmatism. So uncorrected or underestimated pre-operative astigmatism can become more apparent post-operatively, or can interact with the surgically induced astigmatism in a way to produce some residual refractive error. Then there is something called as posterior corneal astigmatism. It is often overlooked in preoperative assessments. It contributes to total refractive astigmatism. It can cause unexpected post-op astigmatism if it is not accounted for. And also there is obviously surgical variability from surgeon to surgeon. So maybe the same patient, same eye, if we could simulate between two different surgeons, would give two very different
Correct.
results and result in astigmatism in one case and not in the other. So yeah, that.
Yeah. Actually, we are talking about one is the pre-existing and the second one is the surgical. You can get
Induced,
refractive
right, sir?
surprises. All these refractive
Absolutely.
surprises will come definitely. And again, it is customized to the surgeon only. That is why all these
Absolutely.
surgical procedures are done with one surgeon rather than multiple
Thank
surgeons. So whatever, thank you so much. You covered the surgical induced astigmatism very
Right, so
beautifully,
because that
madam.
is how
Yeah,
we
yeah,
usually see
yeah, yeah.
it,
I
right?
thought the question was about pre-existing astigmatism. Both ways, anyway, it is useful for the PGs to know. Thank you so much, ma'am. Yes, ma'am.
Thank you, sir, for such
Yeah.
a wonderful talk.
Thank
This is Dr. Tolika.
Hello, madam. How are you?
Good, sir.
Yes.
I but just one point I wanted to add for the PG point of view, not for the people who are already operating. So that it's very important. Whatever Dr. Amita told you, it is very important. One point before that, that whether you're dealing with pure corneal astigmatism or not. So when we calculate the pure corneal astigmatism, then we decide the choice of the lenses. So for example, if you decide the choice of lens should be toric, then it can correct only your corneal astigmatism. So if you take into account so that it's easy to counsel patient that what you're going to correct. Sometime when this is not corneal astigmatism or it is irregular astigmatism, these things will not work. So all these counselings are very important for the post-operative good results.
Absolutely, madam. Because we choose the toric for a non-corneal toricity, then you'll end up in an opposite power, which would be more troublesome to the patient. Absolutely.
Yeah,
Thank you
and
so
Tori,
much.
sir, I have one question for the PG point of view. Would you like to enlighten us on the type of cycloplegia you are using depending upon the refractive
Okay.
error?
Okay. So basically, cycloplegics are, what as a refractive person, depending on the age. So we use homotrapin for youngsters. Then we use the main problem is how we want to assess. It should be cycloplegic. Today we don't have only the Medriatics. Phenylephrine is no longer there. So we have choice of tropicamide or cyclosin, homotrapin or atropine. Very, very young age children, we do atropine refraction and then we take a 2 week break before the post-Medriatic test. Younger people can be taken with homotrapin and little above we can take cyclosin or tropicamide. Only thing is there is always a difference of opinion regarding the how much of drug correction we will give. So atropine is -1, homotrapin is -0.5. Tropicamide, many tell that there is no drug correction. It is a cycloplegic. There could be a zero point 0.5 to 0.75 component. Depending on the age only, we select the drug choice, madam. Anything you want to add, you can add.
No, sir, thank you very much.
Uh,
I just wanted to add one point regarding pseudomyopia or accommodative spasm. So I need your opinion also. So when we find that there's a pseudomyopia accommodative spasm, we would like to prefer in any age, we prefer something which is strongly
homotrapin.
cycloplegic.
Yes, madam.
So hometropin or atropine can be used for such.
Ideally, homotrapin on demand. Pseudomyopia, especially we see in young children, but we have seen other in adults also pseudomyopia occurs. So minimum homotropia should be good. Homotropin should be good. Younger children, ideally atropine.
Thank you very much, sir.
Ointment, madam, ointment especially.
Yes, sir. Thank you very much. So that is wonderful discussion
Yeah,
we
yeah,
have.
yeah. Yeah, yeah. I hope as
Anita,
long
over to
as,
you.
yeah, yeah.
Thank you, ma'am. Thank you for your kind comments. Thank you so much, sir. Sovreen, any other questions that we have?
No, ma'am, not yet. These were the questions.
Okay.
I would request
Okay,
all
sir.
the audience to post their question on YouTube, Facebook, or any other platform because our team keep checking the questions and we would like to answer you. You can share your email IDs with us and you can ask such questions because the iFocus team is always ready to answer such questions and we will always help you with this. Thank you very much, sir. Thank you for the wonderful session.
Okay.
Thank
It
you.
was wonderful being here for the first time. Thank you all. Thank you so much. God bless
Thank
you
you,
all.
sir.
Thank you
Thank you,
so
sir.
much. Thank you.
Thank you. Thank you. Thank you,
We
Tulika,
can
ma'am. Thanks,
uh,
Sovreen.
we can
Thank
stop
you,
the
ma'am.
share YouTube.
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, sir.
Sunil.
Yes, sir. We can log off,
Uh,
sir.
okay.
So,
I thought if they log off. Sunil, can you stop YouTube?
so he will. He will.
Suvin,
You,
Suvin,
you,
Suvin.
so,
Uh,
yeah, you can leave the meeting. We will do that, sir.
okay. Thank you
Yeah.
so much.
My pleasure, sir.